Welcome back to part 2 of the September 2020 BJ360 podcast. I'm continued to be joined by Professor Ben Ollivere from Nottingham and Mr. Brett Rocos from Toronto. So picking up where we left off, guys, I'm going to start now with my 3 papers to highlight from the roundup section. Really, the theme that sort of joins them is I found them interesting because I could immediately relate to them to clinical practice. You know, they were pretty simple papers with simple messages, and I thought this actually makes me think about the job we do on a day-to-day basis. So the first one was from the trauma section, which was a paper from Adelaide, and it was looking at the prevalence of rotational malalignment in tibial fractures following intramedullary nailing. And it's something that I think we all sort of, try and think about at the time and certainly worry about afterwards. But this paper highlighted that actually they noticed in up to 25% of their tibial nailings, there was a 15-degree or greater difference between the injured and nailed limb compared to the contralateral side, which is certainly quite stark. I would say that 15 degrees, we would probably say that was important, and we'd like to all think we're better than that, and I suspect this paper suggests, we're not. But the other interesting thing this paper mentioned is that they noted this was far more likely to be identified in the left side compared to the right, and that's because in the normal anatomical limbs that they compared, there was a 4-degree external rotation difference between the right and left, with the right being externally rotated. So that was an interesting observation as well as part of that paper. The second one was from the children's section, and this was a paper from San Francisco looking at the popular topic of the contralateral slip in Sufis. And they were basically trying to find predictive factors, as is common theme in this area of the literature. And they identified age less than 11, an Oxford score less than 20, and an epiphyseal diaphyseal angle of less than 21 degrees were all independent factors associated with subsequent slip in the other side. But interestingly, when all 3 of those factors were present, the risk of subsequent slip was 70%. And that might be of interest to our colleagues who do children's, in particular pediatric trauma, in trying to predict when and if the contralateral pinning is relevant. And finally, from the research section, I thought this was a real gem of a paper. And this work from China, from Hao, looked at the bacteria found at the initial debridement of open fractures and then compared it to subsequent causative organisms in infections that they treated. And they found, as is probably predictable, that the most prevalent causative organisms later on were gram-negative or more polymicrobial, but in 60% of cases it varied from the initial one cultured. And I thought that had immediate implications to our practice. In A, how often are we achieving samples, and what samples are we basing treatment on? And B, where are these other bugs coming from? Should we be looking at, and there's lots of literature obviously coming out about negative pressure dressings or occlusive dressings, etc. But really, if we're having that many differences in terms of the bacteria at various stages, should we be really honing in on how we manage our open fractures? So they were my 3 to highlight. So if I come to Professor Ollivere, you're going to give us a look forward, is that right, into what will be the October edition of the 360?
Yeah, a couple of papers to whet people's appetite, Sarah, although I'm quite interested in and I remember editing it as Brett submitted his edited summary of the C-spine paper, and I think it really is relevant just across the whole of practice. And I remember reading and thinking, whether that's because they've had lunch or not, whether it's because they're later on, whether it's because the nursing staff haven't got them right, whether it's because they get to recovery and everybody wants to go home and just puts them onto the ward. And I think, it is just worth bearing in mind. One of the joys of 360 is you get easy access to literature from outside of your specialty, because I never would have read that had I not been involved with 360. And I think that's really important. And I've tried to pick my papers around a theme, and maybe I shouldn't have done, having heard Brett's little picks and your little picks. But I've chosen to pick something I think is highly topical, actually, and it's relevant to everybody who's got a trauma practice, and probably everybody who's got a spine practice or anything by a pediatric practice, actually. And that's sort of catastrophic bone failure and how we manage that. So I've chosen 3 papers to do with supracondylar fractures of the femur. And as you know, the problem here is that as you get older, your bone changes shape, and not only does your bone change shape, but it becomes osteopenic, and the constructs that we put in are becoming increasingly ambitious in order to try and prevent periprosthetic fracture, try and prevent fatigue failure. And on the one hand, if you sort of heal with steel, there's the the advantage that it doesn't result in failure of the metalwork quite so often. On the other hand, you've got the biological issue. So I'm just going to run you through 3 very quick papers, which I think put into perspective this issue with distal femur. And the first one is a paper from Wright et al. From California. And what they were asking was, what is the best kind of supplemental fixation? So it's become pretty popular in the States now, and it's becoming more popular in the UK, not just to put a nail in or a plate, but to go, well, one's good, so maybe two's better. And they looked at a nice little paper looking at dual plate and plate nail constructs. A plate nail construct being essentially a nail and a plate where you lock the screws through the nail, those who haven't done them. And obviously you've got vastly different biomechanics there. So they did a whole lot of initial experiments on 24 synthetic osteoporotic femurs, and they then went on to refine that in paired cadaveric studies, cadaveric specimens. And what they essentially were able to do was to quantify the increased stiffness that you get from these constructs, and essentially demonstrated that the dual plate constructs were much stiffer than the plate nail constructs, which they concluded was a good thing. And obviously it is a good thing if you want to make it stiffer, but if you don't want to make it stiffer, then perhaps it's not such a good thing. But it's good to understand the mechanics behind this, and which is why essentially I've chosen 3 papers on the same topic, because that then brings us on to the second little snippet, which is about double plating of the femur, and it's from Rocos et al. Based in New York. And what they were looking at was what happens to the blood supply. And it's a really fascinating paper. It's a cadaveric paper, but they did contrast CTs and MRI scans on their cadaveric specimens. And how on earth they did that, I'm not entirely sure, because it sounds sort of implausible. But they did, and they were able to validate it. And they looked at filling the vascular supply, then undertook their plating, and were able to look at what happens as far as the blood supply is concerned, which is one of those things that's always worried me about this sort of dual plate construct. And they found that actually there was only 4% difference in terms of damage to the small vessels from dual plating versus single plating. So that kind of, it is potentially a practice changing thing for me, because I wouldn't have considered dual plating because of that kind of strippage, AO dead bone sandwich kind of thing. And it is becoming more popular, and maybe it is because you can get away with it. And that paper sort of highlights that potentially as a thing. And just as an aside, they established that plating the distal femur full stop reduces your blood supply by about 20%. So it's 20% versus 24% reduction in the blood supply. Of course, they haven't told you how safe it is to daddle around on the distal medial end of the femur, and not for the faint-hearted, but I do it occasionally. And that brings me to the third paper, which kind of explains perhaps the reason that people are looking at putting plate nail constructs or dual plating, which is a paper from Greenville in South Carolina. It's Bedard et al. And they just asked the question, really, do the distal femur plates fit? And so they took CT scans of intact femurs, a pretty straightforward, kind of resident registrar project. They used TraumaCAD. They had, I can't remember how many exactly, it was 32 distal femurs, and looked at the common brands of implants. And amazingly, on average, the best fitting plate, which was a striker plate, stood off by 5 millimeters, half a centimeter. So it's not surprising if you put something on like that, a cantilever, or you don't put it on as cantilever and you overreduce the fracture. So you're giving the patient a varus or a valgus deformity, they're going to have a problem. Next up was the Smith & Nephew plate, with 7 millimeters. The Synthes plate, a whopping 8 millimeters off the femur, and Zimmer a whole centimeter, 9.3 millimeters off the femur on average at the widest point. So maybe the solution here is to make implants that fit, rather than taking the implants that don't quite fit and adding a second one to make it stiffer. So I thought those 3 papers just kind of sat together really nicely and told a story about a problem and maybe the solution for it. And maybe my own view is that we should be thinking about either accurately contouring our plates or maybe coming up with some better ones that do actually fit the average femur. So those are my 3 little picks.
Yeah, I really enjoyed those, Ben. Actually, I like the theme between them. They do sort of lend themselves to discussing as a group. It's something that comes up quite often in discussion, and I, being north of the border, we're sort of slightly spared from this. But in terms of best practice,
is that sunshine you're talking about?
Listen, I won't tell you the figures about Glasgow and the number of days of rainfall. It's too depressing to talk about right now. But yeah, so the best practice tariff in England, my understanding is that some of the standards that apply to neck of femur are going to be rolled out and applied to femoral fractures, potentially later this year or next. And, you're going to need we're going to need to be fixing these femoral fractures in osteoporotic patients in a way that allows us to mobilize them day one, which is what we expect of our neck of femur fractures. And for me, that means that there's going to be a significant increase in interest in these either nail plate combinations or dual plating, as you say. So definitely an area of big interest.
I think there is. I think, talking about that from a philosophical perspective, and it is interesting, you can't prioritize everything because you end up back where you started. Mm-hmm. So how much do you prioritize in order to get things to the top of the list? One of the things that worries me a little bit, although, it is my friend and colleague Chris Moran who pushes these things forwards, and, he's a wise man. But one of the things that we fail to do in the NHS and in hospitals in general is increase capacity. So if we make too much stuff an urgent target, we've got to do ankles within a certain period of time, we've got to do hip fractures in a certain period of time, femoral fractures, open fractures. What happens to the poor little old lady with a wrist fracture who's there, a number of days later, still sitting on the ward? So there is I think it's absolutely right. Don't get me wrong that we can strive to do better, and particularly for the frail patients. But I think it's really important on a local level that these things are used as levers to increase capacity rather than just chasing the target and artificially making other patients wait longer. It's something we've really got to do as a system change lever, rather than simply become target driven like a lot of family health and general practice doctors have become. Where you go in because you sprained your ankle and you get your cessation of smoking advice, and they tick 2 boxes. Yeah,
I think they're very valid points. And on the second paper there, we had a discussion recently, actually to do with proximal tibial fractures. To do with the anatomic plating system we're using, and the designers of these plates tell me that the proximal tibia is the most anatomically varied area in the body, and that's why none of the plates have a perfect fit and things. So actually, it's very interesting to hear about the studies of the distal femoral plating fitting, because it's sort of the problem with the anatomic. I suppose they're just composites, aren't they, of everyone's anatomy, and therefore they actually anatomically fit no one.
Yeah, and it's not rocket science, isn't it? We've all done knee replacements. Knee replacement systems come in 2 sizes, sometimes male and female, and they get 2 sides, sometimes male and female, and a bunch of sizes, normally 6. So, that gives you at least 12 different geometries, and yet we're surprised when one average plate doesn't fit every single femur.
Well, surprised. I don't know if I'm ever surprised that mine don't fit, but, disappointed maybe. Yeah. So no, I take your point. But we haven't said anything about spine or peds for about 6 minutes now. So if we can wake Brett up, we'll move on.
Yeah, I'm feeling left out.
Yeah, just chime in. If you're waiting for Ben and I to start speaking, nothing would ever happen, would it?
Yeah, our implants aren't typically anatomically fitting. We contour our own rods. Our cages are fairly uniform in size and shapes. It's not something that we encounter too often, though. You do see it with occipital condyle plates and occipital cervical fusions and so on. So I'm sure it will come to us eventually. But it's interesting that, going back to Ben's point about the knees, every single patient of ours, the rods are a different shape. There is an infinite variation, and we don't think too much about it. In the old days when they did use plates, they were using 1/3 tubulars and what we now call the recon plates to fix pedicle screws, and we're contouring them as well. There was never an attempt at anatomical implants in any shape or form. So, I think it's this personalized thing is coming. What we are seeing on this side of the Atlantic now is more and more sort of customized implants and so on, using 3D printing. So I'm sure that's the future, even in trauma.
We'll just wait.
Even in trauma.
We're going to move on to the
back. I'm sure it's a great idea, Brett.
Yeah,
hang on there with your busted femur. There's an anatomical plate coming. Don't worry, the printer's just on it.
That's right.
Long traction for 6 days and anatomical plates. Perfect. Right, we're going to move on to the sort of the main course, as it were. So the paper that I had highlighted for discussion, guys, was a paper from Florida, which was in relation to the modern results of functional bracing of humeral shaft fractures, a multi-center respective analysis. And this is from Serrano and Shah in Tampa. And I picked this one really because, humeral shaft fractures and when do you leave them alone, when do you intervene, which ones need fixing, I think is just a question that comes up every fracture clinic. Is this okay in a brace? Is this brace all right? This brace is rubbing, do we need to do anything with this? And I think it's an area that, we could never be too well informed about, basically. And what the guys in Florida did was a large retrospective cohort, essentially. And they took data from 9 level 1 centers in the US. So we need to sort of, I think, just acknowledge the fact that these are all big trauma centers in the US from over a long period between 2005 and 2015, so 10 years worth of data from these 9 centers. And they based their analysis and conclusions on the follow-up of nearly 1,200 patients. And the big headline of this paper was that only 71% of those 1,200 patients went on to heal without some sort of surgical intervention. So the big headline is, almost 30% of patients ended up with some sort of intervention for humeral shaft fractures. Now, they only looked at shaft fractures, nothing with an extension into the shoulder or elbow joint. They excluded any patients that had an ipsilateral, additional upper limb injury. So whether that be elbow, wrist, forearm, whatever, they all went. So it was all humeral fractures, and basically there was a quarter of proximal fractures, quarter of distal diaphysis, and half of them were in the middle. So that was sort of the spread, basically. They looked at, this paper was interesting, I thought, because it actually built on the lead author had already published their results of their single center, which again was quite pro-intervention, or rather certainly highlighted deficiencies in purely conservative management of these fractures. And I think they then went and made this much larger collaborative paper. So in terms of their treatment algorithm, so that we can compare it to our practice, they said that these patients were seen in the emergency department and they were put into a coaptation or splint or back slab, so a sugar tongue splint or a back slab for 2 weeks. And then they were brought back to the fracture clinic at about 2 weeks, and they were assessed for the adequacy of the position. And they defined adequacy of position as less than 30 degrees of varus valgus, less than in the coronal plane, less than 20 degrees of AP angulation in the lateral, and less than 30 millimeters of shortening. So if you passed all of those tests, you were put into a functional brace. They were assessed at 4 weeks, 8 weeks, 3 months, and 6 months, or until they were radiologically united. The analysis they've done, they've described the stats that they've employed, which look like, robust stats, no big alarm bells there. One of the downsides that I saw when I'm initially reading the paper was there was no power calculation with this paper. So it's just large numbers. But in fact, they retrospectively did a post hoc power analysis and said that the numbers were sufficient to detect a small to moderate effect size, which I thought was lended credence to the results. In terms of, just before we go into the analysis, one of the limitations of the paper is that they initially actually found about 1,500 patients that were suitable for this study, but lost 290 of them to follow-up, basically to either non-attendance or migration out of region, and those patients weren't followed up. So that's about 20% actually. So it's really a conclusion based on an 80% follow-up. So they followed these patients up and they said, okay, well, what were the reasons for intervention? And they basically they've identified 4 reasons why surgery would become advised. And that was clinical, which was movement or pain, or radiological signs of a non-union. The pain or non-compliance with the brace because of rubbing or inability to wear it for some other reason. That the fracture reduction had been lost and wasn't regained on reapplication of the brace. Or a persistent radial nerve palsy, which required exploration. And they found that union was achieved at an average of about 15 weeks with these patients. So in terms of those 4 reasons, the main one for intervening was non-union, which of their 344 patients, so 29% of the patients that went on to get surgery, 60% of that, or 17% of your overall population, were adjudged to have a non-union and had a fixation because of that. 24% of the surgical population, but 7% of that original group, of the whole group, had a malalignment, unsuitable for continuing conservative management. And 3.5% 12% of the revisions of the surgical candidates, or 3.5% again of the overall 1,200 patients, were unable to tolerate the brace, and a very small number were explored because of persistent radial nerve palsy. So they were sort of their interventions. So putting it out to you guys just at the start there, they seem like reasonable reasons for intervening. Any other things that you see in a clinical practice?
Yeah, I'm going to be really pedantic about post-hoc power calculations, because
go for it.
It's a really important thing, and people kind of misunderstand it, because we've ended up with mal statistics practice, if that such thing exists. Mr. Machin would be upset about the statistics litigation and it going up, because this is one of those things that we do and we don't really think about, and we shouldn't do, because the point of power calculation is to work out how many people you need to work out if you've got a type 2 error, i.e. not finding a difference when actually there's one there. So if you found a difference and then you do a post-hoc power calculation to say there's enough patients to not find a difference, it adds nothing to the study, because you've taken an effect size you've already seen.
So you think basically it's
completely irrelevant.
It's a self-confirming
it's a self-confirming thing. And people world over kind of, it is published and you can kind of do it. And if you read the statistics literature, which I'm really sad to say that on occasions when nobody's looking, I do, you'll find that, the world is split slightly on post-hoc calculations of any variety, but post-hoc power to me doesn't add anything to a retrospective study where you've basically collected the numbers that you have and you found a difference. It doesn't say anything. It just makes people think that you've conducted it with a higher level of rigor than you actually have, because there is a difference, so there can never be no difference. So the post-hoc power doesn't add anything at all. It's one of those things that we kind of read and think, oh yeah, they did it right, and actually it just shows.
I thought the purpose of that was that it essentially prevented you just overpowering studies, saying, well, I'm going to collect data on a huge number of patients.
You've already collected it. When you do post-hoc, you've already collected it. So when you do a sample size calculation, which is what it actually is, what you do is you look at what you'd expect to see in terms of a difference. You look at the populations and you say, well, how many patients would I need to see to avoid a type 2 error? There being a difference and not finding one. But this paper can't have a type 2 error because they found a difference. So they can't have type 2 error. And again, it's one of those things that we do just kind of slightly misunderstand. And so we think it adds rigor and believability to the paper, whereas to my mind, it actually does something slightly different to that. It suggests that they haven't really sought statistical advice, and they've done something that is kind of valid, but doesn't add what they think it does to the paper. So that would be my 2 minutes on post-hoc power calculations. I'm sure I'll get lots of angry emails from cleverer people than me, like Professor Costa, saying there is some reason. But in fact, I'm pretty certain Matt would agree with me on this. There's no valid reason for doing a post-hoc sample size calculation, which is essentially what they've done, because you've already defined your sample. So that was my first thing. My second thing was, I kind of want to believe this paper because it sort of reflects what I see in practice, and there's nothing better than self-affirming your own pre-existing beliefs by reading it in a paper and saying, yeah, I'm absolutely right, which is, we all know that Gus Sarmiento's fallout rate was low. We know that he convinced patients to stay in their splints, but we do know that if you persevere with it, splinting's a reasonable thing for most patients. But the thing that concerns me about this is, 9 level 1 centers, so 118 fractures per year, and you kind of alluded to it. And that means that you've got 1 per month per center. Mm-hmm. And that actually suddenly doesn't sound so believable when you say one patient in, because, they will have had a lot more than one patient that was suitable for bracing. So what have they done? Have they not reported them? So that just adds a little bit of,
Well, that's the thing. I think that's an interesting design thing. And it's certainly something that I wondered, because, I'm not sure that the level 1 trauma centers in America are necessarily the place to pick up all of your
community fractures.
Exactly. So I think it doesn't diminish the ones that they have collected, but it does, as you say, by the time you do the maths as how many we're getting and how often over what period of time, it does start to make you think, okay, well, maybe it's not.
The take home for me is, non-union is more common than we traditionally taught that it is, and we know that because we all do a few. I think the really interesting paper, and it's a couple of years old now. I had to look the reference up while you were talking. Is the paper from Ken Eagle's group.
Is that the New York paper?
That's the New York paper, which is 2017 from JO2, which is entitled Fracture Site Mobility at 6 weeks after humeral
exactly
non-union. And that is a real practice changing thing for me. So you put the two together, there's an easy way to see whether it's going to heal or not, waggle it about at 6 weeks and see whether it moves. And moving it, the non-union is more common than we expect. And suddenly that changes my practice. That says to me, okay, at 6 weeks, if you don't seem to be progressing, bail out.
Yep.
And you probably end up at about the right number then in terms of the numbers.
So, I mean, that was the next thing I was going to go on to with this paper, is that they have, and I think in a fairly reasonable way, they've tried to say, well, can we predict who's going to go on to non-unions or failure of bracings, etc. And the groups that come out consistently in terms of patient demographics they identified were white patients, female patients, and interestingly, employed patients. Now, in a North American system, whether that confers any information about follow-up or likelihood to intervene would be an interesting topic, I think. Another one, when they looked at non-union specifically, alcoholics had an increased risk of going on to non-union, as did high energy injuries, basically cars versus pedestrians. You are more likely to go onto a non-union than if you had a low energy mechanism of injury.
No, I agree. And there's also the thing about brace compliance, and just to make Brett feel involved, because obviously, spinal bracing is one of those things that one reads about rather than does to one's patient. I think.
Yeah, absolutely.
And the thing is, it appears to me that if you lock the if you actually talk to the patient about their brace, their humeral brace, tell them how to use it, how to tighten it, how to do all that kind of thing, what the purpose is, and persuade them to wear it and engage with the treatment, it's probably quite successful, similar to scoliosis bracing.
Yeah, absolutely. A brace on the side doesn't do anything at all. They have to wear it and engage with it and so on. So yeah,
but
absolutely.
I think that's one of the things about the sort of the unsexy side of these, humeral fracture management is actually the time invested in clinic, and also the support for patients in between fracture clinics, in terms of being able to come in, have a look at their brace, it's rubbing there, because again, one brace does not fit all patients, and they do need a bit of customization.
You know what, Sarah? If I was at 6 weeks with a mobile fracture site, and I tried this, brace that was a pain, and I couldn't wash properly and all that kind of stuff, and it didn't appear to be progressing towards healing, I'd get it fixed.
Yeah. I think that's the thing. If Sarmiento's work,
come in and you see patients that come in, they're doing okay, they're back at work, things are progressing, avoid their radial nerve complication.
Well, I think that's the thing. So Sarmiento's work really said that essentially you can brace all of these, they'll all heal, but equally, union at 9 months was considered a victory. Whereas I think for a large proportion of our patient population, and I think all three of us, union at 9 months would not feel like a victory. It would be a significant life-changing event to have a wobbling arm for 9 months. And I think for me, this paper brings up a really interesting sort of philosophical thing, which is that any paper that promotes or any, if you pursue a conservative management of an injury, all of the risk is assumed by the patient. It might not go on to heal, it might not go on to heal in a good position, etc. It might have functional implications, it might have implications in delay for your job, etc. All these things, but they're all assumed by the patient. Whereas any time that we do an operative intervention, we start to assume certain risks. We feel liable for infection or nerve injury, non-union, etc. And I think any paper that is trying to move us from a practice where an injury is largely conservatively managed, to saying let's have an increasingly interventional input to these fractures, is always going to come up against that barrier of this, who is assuming the risk for this going wrong. So based on that, can this paper, you talked about the paper from New York, which same for me, that's the one I always quote, and I always give it a wobble at 6 weeks. But should this give us increased confidence in intervening earlier for some injuries?
So I think we probably already are. I think it's just a bit of emperor's new clothes.
Okay.
So I do. I think, Nottingham is a very conservative unit. You've worked with us, we're a conservative unit. But actually, if a month and a half later the patient has no progress towards healing, I give them an operation. Mm-hmm. But I think it's one of the things we still teach all our residents, everybody gets a brace, but but actually we probably already know the answer. We're just not doing it. We're quite good at picking the ones early that need surgery, and they tell you, they don't tolerate a brace. It's really sore and painful. They come back to clinic, and basically, if you don't give them an operation, then they bring their husband or wife to berate you into doing an operation, and that's normally the right thing to do. What we're bad at is recognizing that we waste patients' time for 8 weeks when we know it really isn't going to heal. We see the patient, there's no progress, it's all a bit wobbly, and you sort of say, keep pumping your bicep, we'll see you soon. Make sure your elbow doesn't get stiff, so when I have to do your non-union surgery at 6 months, I can move the arm. I think we already know it. We should just do it,
We should just, so I think this paper can actually give us a bit of increasing, gusto to say, actually, we know some of these don't do well, and it's not all of them, because actually 70% of them healed absolutely fine, but there's a significant portion here. And certainly doing something that hasn't united, trying to plate it at 6 weeks is very different from trying to plate it at 6 months in terms of, the technical demand of that procedure, the risks involved in it, and all the rest of it. Professor Ollivere is going to go on and say, we know this now. We should be embracing this.
Absolutely. Embracing and bracing.
Okay.
Give them a try. Doesn't work. Do something else, right?
Do something else. Excellent.
So I wanted to discuss the Impact Scott paper. Just come from my dear friend Andrew Duckworth and colleagues in Edinburgh. So that's part of the reason that I feel fuzzy and warm towards this paper. And I know that the whole of Scotland is a happy place, so you probably feel fuzzy and warm towards this paper as well, Sarah.
Absolutely. It's a family up here, for sure.
But COVID has changed all of our lives, and those of us interested in research, you're not entirely sure what to do. And the reason I picked this out is actually because I think it's really well done within the constraints of what they had available to them. So, the background everybody knows, like COVID, it's a bad thing, affects frail people, high mortality. But the things that people might not know, having read the Impact paper, which is basically about the effects of neck of femur or COVID on neck of femur patients in Scotland, is that it came out of the Scottish Hip Fracture Audit stopping. So the Scottish Hip Fracture Audit stops, and a group in Edinburgh think, well, what can we do about this? It's really important for us to know what's going on in COVID. So that's the first thing, is that for me, that's a really proactive, like we're trying to rearrange our service, we're doing all sorts of other bits and pieces, and we're actually going to look after our patients, we're going to audit like we should. So they get on the phone to their various friends around Scotland, and they identify 9 units that are able to recruit patients to a sort of rapid sprint audit. And they do 23 days pre-lockdown, they do 23 days post-lockdown. And is a little bit of a messy paper. It's a paper that does have multiple endpoints, but it's clearly not been well thought through, because how can you think through something that you do on the hop? So there's lots of secondary outcomes, and I think people feel a little bit funny about that. But actually, it's a really good paper. They managed to get 317 patients in very rapidly. They demonstrated that the patients had normal demographics, and they dichotomized the series into pre and post lockdown, basically. They looked at what were the mortality predictors, and they found the usual suspects you'd expect. They did a nice multivariable analysis. So they found that mortality by being older, by having male sex, because men are programmed to die when they have an injury. We know that at all levels. Coming from a care home, increased Nottingham hip fracture score. Another reason I like this paper, they use our outcome score, increased ASA, and whether or not the patient's COVID positive. And they were able to quantify that. Being COVID positive gives you a relative risk 5.5%, 5.5 times of death. Now, obviously that's not a death rate is relatively low anyway. So it's not like every patient dies, and you're clearly not going to leave a hip fracture patient on the ward without surgery. So that's not what I'm suggesting. It just informs, and I think informing and knowing what the risks are is super important. So it increases their risk of death. They then went on and they said, okay, we've collected all this cohort together. That was basically, I think, the primary aim of the paper, is to look at the impact of COVID. They then went on and did a bunch of other slightly useful things, some more useful than others based around the data they've collected. And they went on to look at whether or not they were able to predict the chances of having a positive COVID test. So all their patients had a COVID test, some have symptoms, some didn't. And they sort of unlocked, again, in a sort of bit of a fishing trip, really, they established that having a high platelet count was predictive of COVID. And we know there's some good reasons why that might be, actually, because you do become hypercoagulopathic with COVID for various reasons. And they did a ROC analysis, which is a way of looking at a continuous variable with known outcome and working out whether or not it's good or bad predictor, and found that it was kind of a mild to moderate predictor, but definitely a predictor that was there. They then went on again to look at what was going on with the patient populations, and found there's no difference in the patient population, which I think again is for me the second big message of this paper, which is, you know, a lot of us who've done a lot of hip fracture research, and I've done a lot of hip fracture research now, recognize that hip fractures, really the population is the same in normal times. Whichever hospital you look at, whether you look at Toronto where Brett is, whether you look in Nottingham or in Glasgow, Edinburgh, you know, anywhere in the world where you've got a westernized society where people live to a moderate age and have frailty fractures, there's a very, very classic distribution of comorbidities, of mortality associated with hip fracture, of dependency, of all those things. It's a very static population. It's a really good weather vane of how well a system's coping. And interestingly, they found that the pre and post lockdown populations were the same. And one of the things I think we all really worried about was, you know, what is happening to our patients and our younger patients. You know, I saw patients who presented, you know, 4 months or 3 months after their pilon fracture because they didn't want to present and had to do some terrible things to people's legs that you wouldn't normally have to do. I haven't done intra-articular osteotomies in westernized populations before. I get a fair trickle coming if had their injuries elsewhere, but you know, but with the hip fractures, you know, we did see the same in Nottingham. We saw the hip fractures coming in, and we saw a little increase in them as time went on, as the elderly became a little bit more isolated. Mm-hmm. But it's reassuring to find that they were the same population. They were still being presented. People were not neglecting them, delaying them. They weren't dying at home and so on. So that was my second kind of positive take home from this. And the third positive take home really is that I'm just really impressed they got it out. You know, really difficult thing to do in such a short time, and it's still the best paper in terms of a consistent population where they've mm-hmm. audited all of them, so they're able to make a proper estimate of risk of mortality. If you look at the infamous COVID surge paper, it's terrible, and it's in the Lancet, absolutely terrible, and the orthopedic world has done better than that, and I think that's great.
I think, as you say, I think there were several, you know, really good things about this paper in terms of the topic. And one of them, as you say, was trying to genuinely quantify the risk. You know, if you're a neck of femur patient, your family member is a neck of femur patient during COVID, and then they get COVID, what is their increased risk? You know, should you be more worried? And I think that was a very valiant question to address and try and answer. I thought, again, as you said, I thought it was reassuring that the numbers weren't significantly different, you know, despite the sort of social isolation of these elderly patients. That's probably more of a sort of a social care, topic or advent, but I thought that was interesting. I thought the way that they identified and the description of how they identified their COVID patients. So in this paper, there were, of these 317 patients, there were 27 patients who were COVID positive. And in fact, the minority of those, 6 were COVID positive at admission. And then of that, there was then a further 11 who were positive within the first 2 weeks of admission, and a further 9 who were positive 14 days after admission. And that they touch on that in the discussion. Well, first of all, in the analysis, which is that if you test positive for COVID at any time, not just at admission, you've got an increased mortality risk. And then I thought they very sensibly discussed, and I think this is one of the key things of the paper, is if we see a winter, secondary spike in COVID numbers, how are we going to look after these patients as inpatients? Because they are obviously the most vulnerable in terms of COVID, and COVID has a negative effect on their mortality. So are we going to care for these patients in six bed wards? Are we going to have cohorted space available for these patients? I think these are really important things that we need to look at as a community and prepare ourselves for in the next few months. You talked about, you were very positive about the design of the paper and things. I had a question about it, which is why 23 days? As you said, they did a very good job of getting, good data collected on this population. But why 23 days before and after? And why, what was my other question? The 317, can we do reliable multi-regression analysis on 317 patients. As you said, where there were big differences in terms of there were univariant differences with ASA, age, sex.
So there's a couple of things there. So I don't know why they did 23 days. You'd have to ask Dux that, I guess. My suspicion is they did 23 days because, it's 3 weeks and a weekend. I suspect that's the reason, actually. But I don't know. It may have been that they were collecting data prior to lockdown in the hope of writing a different paper, and then lockdown comes along and they think, well, we'll balance it out and have the same thing. And that there are some more impact papers coming. We've contributed data to them. I'm sure you guys have as well, which are better longitudinal analyses of larger numbers of patients. Which I think they just wanted to get this out. Answering your question about the Cox regression model. So the correct of the multivariable of which they've done a number. So the Cox regression, you don't need to worry so much about the number of covariates because it's continuous data. So you've got continuous data. When the event happened, i.e. death, and you also know what the covariate is that you're looking at. And so you don't need to worry so much about the Cox models. You definitely do need to worry about the multivariable regression models in terms of numbers of participants and covariates. So what they've done, and I'm just screening through the paper because they've got these huge tables of the things that they looked at and screened, right? Yep. And what they've done is they've looked for potential statistical links by selecting covariables with a potential reasonable p-value and excluding the others, which is an okay way of doing it. So you look at everything, you say, okay, what we'll do, because we've got potential interacting variables here, anything that has a p-value of say less than 0.1 or 0.5, obviously it's not less than 0.1 or less than 0.05 wouldn't be traditionally considered to be highly statistically significant, although obviously the cutoff is formally 0.05. So we'll put all of those things in, and then what happens is you're testing less variables for the number. And as a kind of general rule of thumb, you can have around about 30 participants per covariate that you test. So actually, when you look at most of their analyses, they're all right. They're not massively powered, but they're all right. And the reason for that is what you're doing with a multiple regression model is you're essentially describing a population. If you have too many variables, you describe that exact population, and then it's not generalizable. So that's the sort of the logic behind it. But there are no hard and fast rules about how many you use. Again, it's a common thing. It's like the post hoc power calculation you talked about. You commonly see, we had 50 patients and we did a multivariable of these 75 variables. Yeah, sure. And therefore we found the ones that were significant. So I think they've done the best that they can.
Well, I think that was the point exactly, which is that these things, they are not, when they are done and they are done in real time about time critical topics, they cannot be designed with the scientific rigor of having complete free reign on what data you collect and when, etc., and what patients are presented and admitted, etc. So I think that was a good explanation there, actually, of the robustness of the stats. So that was useful insight. Thanks, Ben. Sure. In terms of future research, where we're going from here, as you say, there'll be more studies out about this. I would really like them to explore, the findings in relation to the platelets. You mentioned this, platelets of lower than, well, they mentioned 217 of the, 10 to the power of 9 per litre as a risk factor. And that certainly seems, in a world where we do not have a perfect COVID test, these sorts of associations would seem very relevant to the entire medical community, not just to orthopedics. So I hope that there's more data that comes out in relation to that as well. After that statistical masterclass from Ben, which is, well, no, it's why we keep you around, Ben. Otherwise we'd have, all cut you off years ago, I'm sure. But
absolutely, I'm stunned into silence here.
It's not for my witty banter. I worked that out years ago.
It's not just for your witty banter, Ben. No, it's not. But guys, thank you very much. That was very interesting for me. I hope the listeners have enjoyed it. We have a suspicion that this evening's podcast may run slightly longer than the anticipated usual length time, but we hope that you've all sort of stayed engaged and enjoyed that. So guys, thank you very much for joining us. That draws us, I think, to the end of the podcast. So thank you very much there to Professor Ben Ollivere, Mr. Brett Rocos joining us. And thank you very much to you listeners for joining us. And I look forward to welcoming